Okay, it looks like we're right at 5 o'clock. We have guests in the room with us. Gonna give it another minute or so, see if we have anyone else come into the room before we start the introduction. And we have had some put in the chat where they are joining us from. If you would like to go ahead and do that so that we can see where everybody is this afternoon or this evening. Vicky's joining us from Texas. We've got Adrian from Philadelphia. My hometown, New York City, is represented. Welcome, everyone. Hi, Stephanie, South Alabama, Mobile. Daniel's here. Daniela is here from Hawaii. That must be Medex family. Welcome. Hi, Nalay. Good to see you. All righty, let's go ahead and get started. I just want to say welcome, welcome, welcome to everyone to our webinar this evening. I am Donna Murray, the Clinical Training Project Outreach Director for the PAEA ORN2 project. And before we actually get started with the webinar, we're going to put on some information for you about our PracEd PASUD curriculum. So as we all know, which is part of the reason we're here this evening, there's been a rise in substance use disorder, which means there's an increasing need for PA graduates to be equipped with the right knowledge and solutions to identify and treat patients who have been caught in this growing epidemic. Over the past few years, PAEA has been committed and has been working with PA students and educators to develop a standardized substance use disorder curriculum. This curriculum is called PracEd. After 2 successful pilot periods, the curriculum is now available to all interested PA member programs. And there's some information for you on the screen. There are 5 modules in the curriculum, should be delivered in 30-day windows, and it takes approximately 6 to 8 hours to complete. And for more information on the SUD curriculum and to apply, you can visit the website, and the website is there on the screen for everyone. So again, I am the Clinical Training Outreach Project Director for the ORN2 project. I also oversee the Clinical Sites Initiative. I've joined this evening by colleagues Brent Bisking and Christine Vucinich, who are helping to produce the event. Today, we are presenting Enhancing High Quality Training about Substance Use Disorder. Our facilitators this evening are our PA colleagues, Jim Anderson and Bernard Stuetz. Before I ask the presenters to introduce themselves, I'd like to give a few housekeeping items. We will take questions in the Q&A box. Please use the Q&A box for your questions. It helps us to manage them there. If you have other information that you would like to share, please put that information in the chat. As a reminder, the session is being recorded and will be available on the Digital Learning Hub for our colleagues who may miss this evening's event. And with that, I will turn it over to Jim and to Bernie to introduce themselves.
Thank you very much. It's really great to be here. I have attempted to share my screen. It looks like it's shared now. Is that correct? All right, I'll take it as a yes. If it's not,
You're good.
Okay, great, thank you. So let us introduce ourselves if we could. Thanks for the nice introduction. And we're really happy to be here. It's really nice to be able to work with PAEA as far as promoting high quality education for PA students, related to substance use disorders. Both Bernie and I are primarily in the opioid use disorder field, although Bernie, I think, also does a broader spectrum of use disorders than I do. And that's sort of where our background is. So I'll just quickly introduce myself. Jim Anderson, PA. I work for an opioid treatment program in Seattle. I've called Evergreen Treatment Services. I've been a PA since 2000. I've spent most of my time as a PA in either addiction medicine or pain medication or pain medicine, two areas which certainly overlap quite a bit. So I've been involved in Society of PAs in Addiction Medicine, which we'll tell you a little bit about for a while. And Bernie was really one of the founders of it. So Bernie, why don't you go ahead and introduce yourself?
Thank you, Jim. I'm Bernard Stuetz, and I've been a PA for many years, and worked in my background is started in pediatrics, went to internal medicine, and got into addiction, and found out that there was a huge need for me and enjoyed doing it. I work in a outpatient treatment methadone program, and also do buprenorphine or Suboxone at another clinic. Both are a huge need. I'm in the Philadelphia area, Philadelphia, Pennsylvania, and just a huge need for both of the jobs that I have, and I just love doing it. And there's a huge need for PAs to be doing more of this. So sit back and enjoy what we're going to share with you. And if you have more questions, please, our emails will be at the end of this session. Jim wanted me to start out by telling the background on our organization. So the Society of PAs in Addiction Medicine is a group that started in 1994 and really started trying to find our way. And then in 2000, I mean, methadone, by the way, it's been around since the 60s, and it was been highly regulated. In 2000, the legislation for buprenorphine or Suboxone came up, and I got interested in the advocating end, trying to educate legislators about the value of what PAs can do for substance use disorder before it was a so-called epidemic. And my problem was, well, do I go to Harrisburg or do I go to Washington? So Suboxone helped me out in that I had something to specifically talk about, and that was to get PAs into the legislation. We'll talk more about specific legislation later on, but I just wanted to give you an idea of what our organization does. We educate the AAPA staff, and also educating, when I go to Washington, educating the staffs of the different senators and House people as to what these medicines do, how they work, and what the legislation could do to get more PAs into it. And what I've had to overcome was a lot of the myths and stigma around addiction medicine and methadone and buprenorphine. So education has been a big part for me in educating the staffs. AAPA recently has really come around and found us to be very helpful in guiding them as to what legislation to back, and that's been very helpful. So we've worked well with recently with AAPA and educating them, and they've been very helpful listening to us. Let me finish now. That's the short story about our group. Okay,
Yeah.
that's it.
Yeah.
Yeah.
Great. Thanks, Bernie. Thanks a lot. And I think those of you who know or have been involved in the AAPA or have been involved in the politics of the AAPA, there are specialty organizations, and there's a variety of them. And PAs in addiction medicine is one of the approved specialty organizations of the AAPA. And something else that SPAM has done, it's funny, when I say that, sometimes people try and pronounce it like SPAM, and I think that's pretty funny. Like, for example, JAPA, which is the the Journal of the American Academy of PAs, and I was on the editorial board for a while, and some people would insist upon calling it JAPA as opposed to JAPA. So I think it's funny how people end up pronouncing it. It's also funny because sometimes if we send an email with, like, for example, we have a listserv. That's one of the other things we do is we have a listserv. We try to create a sense of community amongst PAs who are interested, PAs or friends of PAs or PA staff who are interested in addiction medicine. And so that's one thing we've worked on as far as trying to add value to those who want to join us. And also just a word to y'all is that the price is right for membership in PAs and for addiction medicine, as in it's free. So we still trying to add some value to that. But sometimes when I send email out to our listserv, or I'll send an email to somebody and the email will have SPAAM in it, sometimes that'll be flagged as spam. So that, I think when spam first started, maybe it was pre-email, but it's a funny side effect. And spam, the food is also always a hilarious thing too. I see we have somebody from Hawaii on the call, and so I went to high school in Hawaii, and I learned to love spam there, fried spam anyway. I don't think I could eat it if it wasn't fried, but that's who we are, spam, one of the specialty organizations. One of the things that Bernie talked about. Well, actually, let me step back a second. One of the things we're trying to frame here and offer value to this organization and this group who are here, which are primarily probably PA educators, is trying to help the PA educators really frame what are the points that PA students need to have when they have some training about substance use disorder or opioid use disorder. So the things we're covering today, we think are things that we've come to believe are really some of the most, the most basic salient points. And if people can leave with, if PA students, when presented with curriculum, can leave with these, we think these are really some of the most salient points that we've come to believe that over our time as PAs. One thing about, maybe I'll talk more about this when we talk about medication-assisted treatment, but one of the things that's interesting about opioid use disorder is the restrictiveness of methadone. And there are many barriers to treatment. Stigma is a huge barrier. We'll talk more about that. But the restrictiveness of methadone, which I think is a reflection of stigma, is also a really big deal. In where I work, opiate treatment program, federally regulated, et cetera, it is so restrictive. Patients have to come 6 days a week. And, the rules, many of which are dictated by our many overseers in the regulatory field, are extremely discouraging to patients. There are so many, they have to come 6 days a week. And some of the rules are very punitive. If you miss 2 days, then your dose is decreased. It's in many ways not a medical model, and that's something I think that Bernie and I and anybody who's worked in opioid use disorder field has faced. Is so much of the milieu and so much of the foundation about opioid use disorder, particularly the use of methadone for the treatment of addiction, is extremely restrictive and extremely unmedical. I mean, if somebody had diabetes, they would say, well, you missed your last 3 doses here, so you're going to have your dose cut in half. Or, you've not been coming here, so we're going to kick you out of treatment. I mean, these things would be unheard of and probably would be the grounds for massive complaints to medical boards across the nation. But such is not the case with methadone, and there doesn't really seem to be the will to change that, in my perception. So that's really one of the challenges that anybody who's in opiate use disorder field should know about. And also I think people who are considering going into the field, which is, I guess, it's a great time to go into it, but that can really be one of the challenges as far as dealing with the restrictedness of it all. You know, Suboxone, buprenorphine, of course, is much less restricted. And that's one of the wonderful things about it. So that's hopefully, we hope that's progress. Let's see here. So I'll talk a little bit about this. I'll get this going anyway. I know that key, in my perception, key to having a solid teaching program in a PA program about SUD and OUD is having quality preceptors and preceptors who work in the field and who are excited about working with students. I know that from my discussions with people in the PA education field, you know, preceptors and finding preceptors and keeping preceptors can be an incredible challenge. I think COVID probably set that all back by 10 years or so, because I know that it has been even more difficult for programs to find preceptors. And I hope that's getting better now. Where I work, we historically have had a strong relationship with the medics program here in Seattle. I went to the medics program, and as such, we've always been really proud to precept PA students here. But with COVID, you know, it changed, you know, concerns about infection control, also space limitations, you know, all the issues that any preceptor will say are some of the issues, but those really have got in the way of us continue with that tradition. So we're working on trying to bounce back from the COVID era. But one of the concerns, of course, is the COVID era is not over and may not be over for a while. So that's a challenge. It's a challenge for preceptors, and it must be a challenge for you. One of the things that we also think is really important, and it's been a challenge for us, is try how to get opiate use disorder or substance use disorder topics on, you know, on conferences or presentations or lectures. And that's why we feel so pleased and so lucky to be able to be presenting, you know, under the auspices of the PAEA here, because I think it's very important. Bernie and I have, you know, I don't know, since 2000, been trying to get a opiate use disorder lecture on the docket for PA conferences, for the AAPA conference. And I think we sort of gave up a couple of years ago just because we weren't able to do that. I think there are a lot of reasons for that, and I don't exactly fully understand them all. Certainly conference planning, for those of you who are involved in it, is complex and expensive. But I think but it's been a frustration of ours as far as not being able to get these things on the docket, because that's one way to recruit students. That's one way to recruit preceptors, is to get this information in front of people at conferences where people are going. So we continue to do that. And that's, again, one of the reasons we're so pleased to be able to be speaking to you here under the the green and blue PAEA flag. Let's see here. So Bernie, you want to start with this one? And again, these are topics in no particular order that we think are topics that PA students should leave the room with when they've heard a presentation about opioid use disorder or substance use disorder. Go ahead, Bernie.
Okay, thanks. Little history here about methadone. Methadone was invented by Hitler. Yes, Hitler. He couldn't get morphine into Germany during World War II, so he had his scientists create this chemical for pain. And he found out, he tried to give it to his soldiers, but found out that they weren't very accurate in their shooting. So he didn't give it to everybody, but he did find a new chemical. And in the 60s, two American physicians, Dole and Nieswander, got 22 patients in the New York City area and developed and used methadone to prevent their narcotic hunger, as he put it. And it blocked the euphoric effects of this on patients. And from then it became much more widely used. And in the 70s, we had the Controlled Substances Act, the federal government got involved in, and that's why methadone clinics are highly regulated right now. The one thing I want to mention before I get into the slide is about stigma. The stigma is around methadone is huge. And I just have found a lot of this misinformation present with, and mainly physicians, that they're not well educated about addiction. And the organization that we have been working with has been very helpful, and that is the American Society of Addiction Medicine. And it was tough to get in there. They wouldn't accept us as members until 2016. But now that we're in there, we can talk to the policy people at ASAM, and they're listening to us. And we're both advocating for so-called person-centered language to help overcome this stigma. So instead of somebody who's an addict, you would say a person with opiate use disorder. And instead of their urine being dirty or clean, we would say that their urine is negative or positive. So those are some of the language things that will help lessen some of the stigma. Now to get to the slide, addiction is a very complex and difficult disease. The relapse is the norm. Someone starts out in methadone and then they don't come. All right, well, then they got to come back. And as Jim pointed out with the dosage, they might have to start over again. So no, you can't treat it like a cold. And as far as the longer in treatment, less mortality, there have been studies over and over and over again that have shown the longer you're in methadone treatment or Suboxone, the better your chances are for survival. Also, the less hepatitis C and less HIV, the longer you're in treatment. Patient autonomy. Yes, in the beginning, you have to come every day. Jim can talk about his successes with his methadone patients. So what does the success look like? There are people on methadone that are in every strata of our culture. And I wouldn't doubt that there are people in the Capitol Hill who are on methadone. It is everywhere. And it's successful. People go around and they don't want to bring it up because, the stigma is so bad all around. So what does success look like? Well, one of the jobs that I do in my methadone clinic is I do the initial exam when people come in. In the beginning, the first couple weeks or months, if they need an increase, I help them out with that. I examine them and put in the order, send it to my supervising doc, and he puts it in. We do dose reviews at 6 months, and at the annual per year, I'll examine people. Now, because of COVID, we're not doing as many exams, so I'm doing a lot of telehealth. And what I do is remind them to go see their primary doc, because one of the things about addiction is they don't really care about their health, but once they make that switch, then they're, all right, what do I need to do now? So I have a list of primary care doctors. I have a list of GI docs and ID docs, infectious disease docs, to take care of their abscesses or their Hep C. So those are the things I do. And I really love it because I get to see these people who are now taking care of themselves, and then I direct them, go to this doc or go to that doc. That's roughly what I do. Okay, Jim, you can take over next.
Sure, great. Yeah, great. Thanks, Bernie. Thanks a lot. That's really a wonderful description of some of the key points for this. When what does success look like item, a lot of people will ask me, people who are, well, sometimes even people who are in the field, frankly, will be like, well, how long does somebody have to be in treatment? I mean, is a way to measure success as far as like how quickly can they get off the methadone, quote unquote. And I think that the literature would say that that's backwards. That really, it's not a life sentence. It doesn't mean you have to be on methadone forever. And that's where the patient autonomy comes in. Where I work, it's relationship between the medical provider, the patient, the counselors, as far as deciding, is it working? How is it working? Sometimes when you ask, when I'm talking to patients, I'll say, well, okay, who should be in methadone treatment for the treatment of opioid use disorder? And the answer to that is like people who can't stop using heroin or other opiates, fentanyl these days, which is everywhere and everything, but people who can't stop using illicit opiates any other way. So those are the people who should be in methadone treatment or Suboxone treatment. And then the next question is, well, so who should be in methadone treatment or Suboxone treatment for a long-term basis? And I think the answer to that is typically people who are in treatment, who are able to stop using illicit opiates, but every time they leave methadone or Suboxone treatment, they relapse. That's who should be in methadone or Suboxone long-term. And when somebody comes in, you don't know if they're in those categories or not. And the patient doesn't know if they are either, likely. But those things show themselves, and part of it is, I think, treating it like a chronic disease and getting students and other people to really think about it, is that with other chronic relapsing remitting diseases, part of it is coaching patients to be able to accept the fact that they may need to deal with this long-term illness, whether it's hypertension or hyperlipidemia or diabetes or COPD, for the rest of their life in some way. Doesn't mean they have to be in methadone treatment forever, but and I think that's for anybody with chronic disease, people with diabetes. I think a lot of patients are just like, look, I'm not going to test my blood every day. I'm not going to eat small meals frequently. And I don't care if that means I die 10 years early. I'm not going to do it. I mean, there are some people patients who I'm sure you've encountered who feel that way. So it's tough to get people to almost surrender to the fact that you have a chronic illness, and that means that you can control it, but it may take some effort on your part for quite a while. Another thing that's changing about methadone also, as far as Bernie was talking about, is there's a big move within opioid treatment programs and addiction care into what's called integrated care. And I don't think that's a new term to any of you. But integrated model, as far as methadone treatment, is moving away from having clinics where all we do is diagnose and treat methadone, and we farm out everything else to everybody else, or fail in trying to do so, which is often the situation, to actually beginning to put mental health care and primary health care in the same place as opioid treatment. And for example, where I work, we none of the providers perform primary care, but we do have top-notch primary care come into the building once or twice a week, so patients can see a primary care provider with no wait at all and get plugged into some of the best care in the world. But integrated care is coming everywhere, coming everywhere for addiction treatment, and it's certainly coming where I work too. A lot of us who've been in this field forever, like, okay, now we're just going to flip a switch and now we're all going to do primary care. A lot of us are a little fearful about that. Like I haven't worked in primary care for one day of my 22 years as a PA, and I don't think I'd be well suited, but by nook or by crook, but that's coming down the road, is integrated care. And that's probably it's a good thing for patients, although some of us who've worked in the field for a long time are a little worried about what that looks like for us. But it's for patients, it's going to be a very good thing. Let's take a look at another key topic as far as I think it's important for people who are being taught about substance use disorder, and particularly opioid use disorder, to know about some of the basics about medication-assisted treatment. Everyone talks about it now. MAT, really right now, it's basically 3 medications, and really it's almost always only the first 2. I've not methadone, buprenorphine, and Vivitrol. That's the brand name for naltrexone. It's injectable naltrexone. In a nutshell, Vivitrol is a antagonist, much like naloxone, Narcan. The difference is naltrexone is slow acting and long acting, and naloxone is quick acting, which is why you would never really want to use naltrexone to reverse an overdose, because it's slow, it's long acting, and takes a while to get there, to accumulate, whereas naloxone is very quick. But really the 3 key drugs in MAT, medication-assisted treatment. I mean, people in medicine and medical education are always looking for acronyms, and I have people who call it MAT. So whatever the case is, but that's what it is. It's typically methadone is the old school, or the old school one, still very effective. Methadone and Suboxone are considered to be the gold standard for the treatment of opioid use disorder. Vivitrol, some people have had great success with it. We don't administer it where I work, but it's really one of the three key choices. So that's what medication-assisted treatment is. The issue of who can do it and who can't do it has certainly changed. As Bernie was saying, in 2000, it was only 2000 when MDs were able to use Suboxone for the treatment of buprenorphine / naloxone. Were only MDs were able to use that medication for the treatment of opioid use disorder. Then, in I don't know, 2012 or something, was when PAs and nurse practitioners, and also some clinical nurse specialists and some PharmDs now able to prescribe Suboxone. One thing I didn't want to get too much in the weeds, or I don't want to get in the weeds at all on any of this, but one thing I think it's important to know, and I think it's as far as people learning about what are the treatment modules for opioid use disorder. And a key point often missed is that methadone may not be prescribed by anybody with any credential for the treatment of opioid use disorder. End of story. And so, for example, where I work, or any opioid treatment program, nobody here prescribes methadone for the treatment of opioid use disorder. We order the dispensation of methadone, and methadone is dispensed to our patients. Nobody can prescribe methadone, on an outpatient basis for opioid use disorder. And I think that's a point of confusion, and I think it's interesting. And one of the nice things about the new edition of Suboxone, which is buprenorphine and naloxone, of course, then the reason, just as an aside, buprenorphine and naloxone are used together in Suboxone, and the reason is to prevent diversion, because it's oral, film, or tablet, and when that combination is taken, the naloxone, aka Narcan, doesn't do anything. As far as a PO medication, it doesn't do anything. But if somebody were to smoke it or grind it or crush it or inject it, then it would put somebody into big time withdrawal. So that's why those are combined. But Suboxone can be prescribed by PAs, NPs, I mean, throughout the community. And so it's really opened up a lot of things, although still there are patients who come to our clinic who don't believe in, there's a lot of, I don't know, there's sort of sub-stigma, and there's a sub-stigma about Suboxone. A lot of our patients they don't believe it works. They just think it's sort of a scam. They think it's a way to keep them away from methadone. So it's pretty interesting because it's like pulling teeth to get our patients to come in who may be excellent candidates for a variety of reasons, lower overdose risk, for example, safety, but we really can't get them to do that. I think we'll skip about the, so PAs, NPs now can get an X waiver, as you know, and up until recently, PAs and NPs had to have 24 hours, MDs had to have 8 hours. PAs and NPs have been in the field have been saying, how does that work? Is there any kind of data that says that PAs and NPs need 3 times the training of MDs to be able to dispense Suboxone? The answer is no, of course there's not. And now with the Biden administration has made it easier, and so PAs, NPs do not have to get an X waiver or do not have to take the training to get an X waiver to write prescriptions for Suboxone, but it's very limited as far as the numbers. It's 30 only, period, so they can't prescribe as much, but that may be a little bit in the weeds. So, and one thing I wanted to say too about stigma is the medical director who I work with, addiction psychiatrist, wonderful provider, great supervising physician, and but he's funny. He's sometimes I don't know, a little skeptical by nature, because he, and sometimes it bugs him when people use the term harm reduction. He's like, why is it not just treatment? Why, when we give patients who have opioid use disorder, methadone or Suboxone, why is that not just treatment? Why do we have to call it harm reduction? And his point is that's just some more evidence of the stigma. We can't just call it treatment. Nobody calls insulin or metformin for blood sugar concerns to be harm reduction. So I think that's interesting. I think harm reduction, it is a term that allows many people to come into the world of addiction and see it and think about it but I do think that's kind of funny. All right, Bernie, do you want to talk about, actually, maybe I'll take the lead, but I'd like you to chip in on this, Bernie, too. One of the key items that I think PA students should know about when they learn about opioid use disorder is about as Bernie pointed out, there's a very high relapse rate. I mean, it's like many other chronic diseases, it's a relapsing, remitting chronic disease, and relapse is a huge part of it. And so I think there's been a lot of advancement as far as relapse prevention techniques, equipping patients with the framework to view when they have a relapse, calling it maybe something else, terminating it as a slip instead of a relapse, because sometimes when people have a relapse, whether it's like they're on a diet and they're trying not to eat cookies and they have a cookie, I mean, seeing it as a temporary thing that you can move past with some skills versus seeing it as like, no, I'm screwed. I'm right back to where I was, and I'm going to eat this whole bag of cookies. And so relapse prevention techniques are very much in the norm and play, I think, a very key role in the counseling that our patients get as far as the treatment of their opioid use disorder. Where I work, we have and I think it's the same with Bernie, it's a team model. We have nurses, we have counselors, mostly of who are SUDPs, substance use dependent professionals, who are doing an amazing job. And we also have providers here. The providers here are almost all PAs and nurse practitioners, which is a wonderful combination. We work together really well. And that's pretty much what you find these days in opioid use disorder clinics. Although some of the older programs have used different models. Bernie, in the methadone clinic where you work, what is your staffing model?
Basically the same.
Yeah.
The same. We have counselors, and there's a certain number of hours per month that the patients have to get. And then when you don't, in the beginning, yes, you have to come every day, but if your urines are negative, then you can get a take home, so that you end up that if you're really good, you end up build up points and get take homes that you don't have to come every day. You can come maybe once a week.
Yeah.
So you're rewarded for your good behavior.
Yeah, there's a great amount of behavioralism in methadone treatment like that, and I think I understand it. I do know that something of interest in this area, just briefly, is so when COVID came, March of 2020, the powers that be, the EA, SAMHSA, state, departments of health, all of the many overseers that we have, said, okay, we're going to loosen up the take-home rules now, because the rules are pretty tight. Like here, for example, you start coming in 6 days a week, then every 30 days with no positive UAs, you show up your appointments, you're a good citizen, you don't miss any doses, you can come in 1 day less per week. So over a year's period, you can actually get to where you're coming in 1 day a week, but it takes a lot of work for a long time. And really it's your highest performers who are able to get to, which is more of a medical model. You come in, once a week, once a month. But powers that be said, okay, we want to, decrease the risk of infection, viral infection, et cetera. So they loosen up all these regulations. And so now that there's some perception that it's decreasing, although if you look at the numbers someplace, there's still 1,000 people a day dying from COVID, which almost people are just ignoring. But there's a sense that we're moving past that. So now the powers that be are starting to say, okay, it's time for you methadone clinics out there to start tightening back up and get back to the old regulations. And so there have been a couple of studies. One recently just came out of the new medical center at the Washington State University in Eastern Washington. They have a new medical center, and they did a study looking at patients at a methadone facility there. And it's a second of a couple studies that said basically when people had loosened restrictions as far as take-home medication, that even with the loosened restrictions, overdose rates were not any higher. There was really no more behavior problems in the clinic. Nothing really happened. Nothing really changed, even with the loosened up take-home rules. So that's interesting. And I hope that there's more study about that because I think it's important. Let's see. We talked quite a bit actually about stigma, and Bernie talked about the dirty, clean, so forth. There is I'm wondering if most of you know what PCSS is. PCSS is, I believe it's a SAMHSA, Substance Abuse Mental Health Services Administration, federal government agency, and I believe they have an affiliation with them. But if you were to just go online and type in PCSS, it's a website with amazing, it's all free, and it's amazing evidence-based modules about methadone, about Suboxone, about MAT. It's really a great learning place to go. And they also have some wonderful presentations. And one of Bernie and my colleagues from the Society of PAs in Addiction Medicine is named Richard Botner. And he's a PA in Dallas or in Texas. And he's been very active there. He's really a very strong leader in this field. And he did a wonderful talk on the PCSS site about stigma, looking at the history of stigma, and particularly then talks about how it's related to addiction and particularly certain drugs. Really a fascinating thing, something that's an example of something you can see if you go there. If you go to PCS, look up PCS and go there and type in Richard Botner's stigma, you'll see it. And I think there are tons of tools like that, which are really great for students. And so we've talked about the treatment issue, and I think there are a lot of people who still wonder what the hell's a methadone clinic. When I was a PA student in 1999, and I did my clinical rotation here where I work now, and this was my first job after PA school, and I had no idea. I'm like, what's a methadone? What's a methadone clinic? I did inpatient, outpatient, I didn't know. And I think still there are more and more people who do know, and we try and get a lot of students and fellows in here to expose them. But there's still a lot of people, particularly people I know in the community, are like, what happens there? Where do they go? What do they do? I mean, is it inpatient? Is it outpatient? And that's part of, I think, the challenge of opiate use disorder and addiction treatment in general being so almost sort of siloed from the rest of the community. And that's one of our challenges, to not do that. One of, I think, really the strengths about PAs and addiction medicine has been our work, and particularly Bernie's work in legislation and advocacy. Bernie's done an amazing job and cut an amazing profile. And maybe Bernie, you can tell us a little bit about your work in that, because it's been great.
Thank you, Jim. This will be a really short summary of legislation and what I've done. I mentioned 1970, the Controlled Substances Act that helped to regulate methadone clinics. Well, in 2000, this DEA granted a waiver to physicians to prescribe buprenorphine. And PAs and NPs couldn't do that until February of 2017. That was part of the Affordable Care Act. PAs, you get right off the bat with Suboxone or buprenorphine, you can see 30 people the first year, and after a year you go to 100, and then after another year, I think it's 275 patients. Now that's been shifted, and I think you don't have to do the 30. I think you can go right to the 100, I think. They've loosened that up a bit because of the substance use disorder crisis. One of the things that I'm currently working on when I go to Washington is that we have to take a 24-hour class to be waivered and get your X number in buprenorphine. And AAPA and I have been working with legislators in certain bills to try and make that 8 hours. Physicians can take an 8-hour class and be certified to write for buprenorphine or Suboxone. They get what's called an X number, and PAs and NPs have to do a 24-hour. Personally, I think that's ridiculous. And that's another barrier that PAs have to overcome to get that to be able to provide substance use disorder care. So one of the things I'm working on is let PAs to be the same as docs when it comes to education. And the other thing about these numbers that we toss out, 30, 100, and 275, they at my Suboxone clinic where I work, buprenorphine clinic, they keep track of how many I see. And what's not really worded very well in the legislation is it's counted per month, not per year or per life, so that you're allowed to see 30 a month, 100 a month, or 275 a month. That's a good thing, I think. That's the thing I'm currently working on. And again, what I do with the staff is educate the senators and House people on what PAs can do and how we can lessen the opiate crisis. That's really it.
Well, Bernie, can you tell us, I mean, one of the things I think that you've talked to me about is the successes you've had over the years is that is building relationships, that when you go to Harrisburg or you go to DC, that they've heard from you before. They heard from you last year. And
Yeah.
Can you tell about the, the skills you've learned as far as doing that? Is it just basically being persistent?
Yeah, well, that's part of it, but it's also, you're right, with relationships, and certain senators and certain House people are on like Energy and Commerce Committee in the House. And I work through, there's one person from Pennsylvania there, but I also go to the people who sponsor some of this legislation. Lori Trahan from Massachusetts, I work closely with her staff. She's very up and very interested in relieving this crisis and getting more providers out there. And in the Senate, I go to Patty Murray's office from Washington. She's head of the Health Education Committee in the Senate. So and Casey, my Pennsylvania guy, I work with his staff too. So it's really educating them on how their bill can open it up and get more PAs in there. And showing them that what we need, like this 24 to an 8-hour class would be a huge advance for us. And AAPA works well with that aspect. The policy people at AAPA are very doing a good job in advocating for that. And I follow up with that in trying to lessen that 24 to 8. That would be a huge advance if we can get that.
Yeah.
Yep.
And Bernie, you also had a role in the White House at some point. I think is that correct?
Many years ago.
Yeah, that's pretty cool.
Yeah, that was many years ago. Many years ago.
So
yeah, worked on it. Good. Good.
Well, I was also going to add to that the legislative response to addiction medicine and to the opioid epidemic over the past few years, one of the promising things about it is it's been really more. It's been a big combination of Republicans and Democrats, and things are so polarized now. It's very, I don't know. You don't see that a lot right now, and so but that's one great thing about the response is, in fact, it's some of the leadership as far as responding to the opioid epidemic and providing more funding and et cetera, all the things that are happening now has been basically both Democrats and Republicans. Something else too, another way I think to build advocacy. Yeah.
I just wanted to cut in for a second. We got about 8 minutes left. I was thinking we could probably, doesn't look like anyone's had any questions so far, but if we wanted to just pause for a moment to see if anyone had any questions. And then we can.
Yeah, that sounds good. We're wrapping the wrap up phase anyway. So yeah, that would be great. It would be great to hear any questions.
Great. So if you'd like to ask any questions, you can do so in the question and answer box, or you could raise your hand. And I think, Christina, we can unmute your mic.
Sure, if anybody'd like to ask any questions, just raise your hand and we could certainly unmute you and allow you to talk, or feel free to put your question in the Q&A.
Tiffany, I think you raised your hand. You can go ahead and unmute.
So it looks like we don't have any questions right now. Gentlemen, do you want to continue?
Yeah, sure. I think we're just about wrapping it up. I see Tiffany popped up there, but I don't think that she unmuted. But another way I think to something else that I think can be powerful with students is, enhancing them the desire to be advocates, whether it's just participating in PA business, and that are state associations, but also regarding addiction, is teaching them to, build, for the programs, for the state associations, for students, and tomorrow's practitioners to, build contacts within departments of health and medical boards, and also working through state organization contacts. That's, I think, can be, and I'm guessing you all do that anyway, but I think those can be very effective as well. It can be a powerful sort of a grouping to have students and PA and educators and other PAs who are all in practice working together on some of these legislative issues. And that's, I think you all, based on my PA time in PA school, I think you all already pay a lot of attention to try and build students who are interested in doing those kinds of things as well. And as far as paying back those who came before us. So I think that's helpful as well. So I don't have any other comments other than I just want to again say, I really appreciate it. Yeah,
I have something. Just
Sure,
to let everybody know, there is if you go to the SAMHSA website, SAMHSA, that's the Mental Health Division of Health and Human Services, www.samhsa.gov. There is a buprenorphine physician locator there that you can find. Where is there a physician who does buprenorphine? So if you just, there's also a SAMHSA National Helpline. I'll give you the phone number, 1-800-662-4357. 1-800-662-4357. That's the SAMHSA hotline. And so on that buprenorphine treatment locator, there's a state list of practitioners, PAs, and NPs who do buprenorphine. So you can hunt around there. If you got a question, our emails will be at the end of this presentation, and you can email us for help to find where is their buprenorphine locator.
And
Okay,
Bernie, I think that's also maybe a good way to, a creative way to look for preceptors too, in addiction medicine, is to find out who's doing the work now. And that's a really, that's a great idea. And final thought about resources, there's a Addiction Treatment Forum, ATF, Addiction Treatment Forum publication, mostly focused on opiate use disorder. It's good, evidence-based place, a lot of patient level resources, but a good place for students who are interested in finding out more about the addiction treatment to do that. And also another good place to send students who are interested in addiction treatment is to Society of PAs in Addiction Medicine. Bernie and I are very interested in talking with your students and answering any questions that they might have about addiction treatment.
Right, and we put updates there on the listserv. There's updates, yeah.
It's www.spam.org.
Very good.
Well,
Yeah,
thanks a lot, everybody. Thank you.
yeah. Thank you very much for this.
Okay, everyone, we have gotten to a point where we're at the end of our program. We thank you all for joining us this evening. Thank you, Jim. Everybody hear me?
We can now.
Yep.
I don't.
Okay, I am unmuted. I was just saying thank you, Jim. Thank you, Bernie, and thank everyone for joining us this evening. Again, just a reminder that our session was recorded. It will be housed on the Digital Learning Hub for colleagues who were unable to join us this evening. And with that, we are going to say have a good night or a good afternoon, depending on what part of the country you're in.